So, take a high-risk newborn. So you've all seen normal newborns, and some have seen abnormal newborns. And, who had the season questionable baby?
Jenna had it.
Which one? The one that went to the NICU?
Jenna.
They repeated the EEG. The first EEG was normal-ish, they were saying. Repeated another one after, and still weren't sure what was happening, so they're going to follow outpatient. But definitely abnormal.
But they did send him home?
They sent him home, but he needs to be followed up.
How's the one time?
It was actually stable. Oddly enough, that was one of the more stable babies.
The little one?
Yes.
I wanted to ask you,
She actually admitted one of the 4-day-old diabetic,
Really?
so her baby was stable. That baby. What were you going to say?
I wanted to ask you there, like, what that baby's chances were, but I didn't want to.
Oh, there at the hospital?
Yeah, like, you think that the baby will be okay?
It can be. The head ultrasound was normal, I believe. So that right there, first hurdle over.
Good.
So, can be.
Good.
And the baby in the isolation room that had the bizarre organism, repeat cultures were still positive. So that baby still has whatever that Mediterranean germ is. So, management of high-risk newborns. So obviously there's been, huge progression in neonatal care and care of sick newborns. This is a typical scene that you would see of a baby in the delivery room getting some blow-by oxygen to come around and pink up. So there's high-risk factors that can give us an indicator that something might be going on. So that's the best case scenario, is that we know that there's going to be an issue. So some high-risk factors are preconception weight of less than 110. I don't know if it's about single parent, but less than a high school education, so less education sometimes leads to more complications. A febrile illness is a big one. Mothers that have fevers during their pregnancy or during delivery often fall into complications. Maternal age of less than 19 or 17, depending on what reference you look at, or more than age 35, which we talked about as advanced maternal age in the United States. And then substance abuse and smoking. So those are some high-risk factors. Additional risk factors, these may not follow exactly along on your PowerPoint because I rearranged them once we did the newborn assessment in there, but they're the same slides in different order. So some risk factors that place an infant at high risk is less than 1 year since their last delivery, hypertension and diabetes, the big ones, bleeding past 12 weeks gestation, multiple gestations, fetal anomalies, maternal uterine conditions, and a history of a preterm delivery. So I just want to stop for a second and think and reflect now. Hypertension. What is the process of hypertension that causes the fetus to be at risk?
All the blood's not getting to the uterus like it should be.
So the nutrients and all the oxygen that it needs is not going to be able to grow as well.
Exactly right. First two winners.
Thank you.
All right. So what does that result in? So if there's not enough blood flow getting to the uterus, what is that called of the baby?
IUGR.
You got it. All right. Diabetes. We keep touching on it and touching on it. The infants of diabetic mothers, why are they at high risk?
They get big, so they don't.
What?
Oh, as in why the mom's at risk?
Why the baby is at risk? Why is the infant of a diabetic?
When it's delivered.
We're going to do first round quick, lightning round here. Exactly. So the baby's at risk for hypoglycemia.
It's gonna be small.
It can be small, but often they're big babies.
Some deliveries, complications.
Just in case it.
All right, so those are the two in the United States right now, the two big conditions that are affecting high-risk newborns, or putting babies in high-risk newborns. What about bleeding past 12 weeks? What do you know about bleeding past 12 weeks that can place a baby in a high-risk situation?
That maybe be the placenta is pre or something. Something's not right if they're bleeding.
There's
The blood
opening,
pressure?
so some bacteria or something can go up, right? To that.
And what if that was in the placenta? What's not happening between the placenta?
It's not crossing
or
already.
whatever. So
Yeah.
that baby's at risk if mom continues to bleed as her pregnancy goes because the placenta's not functioning correctly. You can answer. Didn't hit everybody this first round. Can you think of maternal uterine conditions that might affect a baby and place it in the high risk category.
When it has the septum, I don't
Exactly
remember what that's
right.
called.
Oh, and the.
What's it called?
What's it called?
What?
The
Oh, yes, biparent uterus. Yeah. So right there, you know, the mom's coming into labor and delivery and they're figuring out all these conditions, and NICU's getting a call. There's conditions here that are gonna place this baby at a high risk.
What if there's too much amniotic fluid, or if there's more than one fetus in there, it could stretch too much?
Exactly right. So fetal anomalies
Right.
and multiple gestations.
Oh,
All right, so you guys hit them. You know, that's a lot of conditions. Infection, touched upon this. Infections place the baby at a high risk things. And they are, the acronym is TORCH infection, and it's toxoplasmosis. The O stands for other, and it's hepatitis B, parvovirus, HIV, and chickenpox, measles, mumps, rubella, CMV, herpes, and syphilis. And as you did your L&D rotations and newborn, you'll see that those are right at the top of the intake sheet. Those are important to know. So as we assess the well-being of the infant, we have to determine gestational age. So gestational age is a preterm newborn, a newborn born before 37 completed weeks of gestation. A term newborn is 38 to 42, and a post-term newborn is born after 42 weeks of completed gestation. NICUs, there's levels 1, 2, and 3. This is a lot of words, you don't have to read. Locally, we have 2 level 3 NICUs, sisters and children's. A level 2 NICU is a NICU that can maintain babies with, you know, probably over 30 to 32 weeks needing a little bit of oxygen. And a level 1 is maternal and newborn care. So here's a preterm infant, clearly born before 37 weeks. If you had to guess how many weeks you think that baby is.
20.
26.
So it could be anywhere in there, if you could get it a little bit clearer, but doesn't look too far off from the real baby that we all saw.
So that was like 25.
That was 25. Yep.
So that one was small for 25, wasn't it?
Yes, because his mom had
Hypertension.
hypertension, yes. Oh, going crazy here. Okay, full term, everybody saw a full term infant. Look at the posture, the head, everything's looking term there. And then post term, a little bit harder to see with the lights on, but cracking.
The skin looks.
Yeah. Hands are all wrinkly. And this is, you know, we say we want creases on the feet, but it's on the sole of the feet. These, you can see a post-term baby often has long fingernails. They look overdue. They're overdone.
Overcooked. Right out.
So how do we decide gestational age? We use the Ballard screening. And this would be applied, I don't know if everyone heard, but you know, on Friday we had a baby born in the parking lot, and you know, you need someone quick there to figure out what's the gestation of that baby. So, if you we take a look at these Ballard exams. Did you get a chance to use these in L&D or look at it in the newborn nursery? No. So, if you look at the weeks, the number that I put there at the top of the paper, you take a look and see if you can look at the findings, look at your weekage on the top of your paper. And then what you do is you look at the score in the weeks. So you add up, your baby's 22 weeks. So she's gonna be on the low side here. And you're gonna see what the physical exam of that is. Nurses do the Ballard exam. So who wants to look at their weeks and tell me what their weekage baby is gonna look like? Katie.
I'm trying to figure out how to do this.
Okay, so let's take a look. So right over here is, all right, so this baby's 25 weeks. I'm just telling you the information. But you would expect a 25 weeker to look up there, it's gonna have a lower score. So a 25 weeker is gonna only have a 5 total out of both of these. So the baby's gonna be laying flat. It's gonna have a 90-degree square window, which is the wrist. The arm recoil, that baby's not recoiling his arms. Popliteal angle, you're holding his knee up and you're pulling it up to his ear to see what the angle is that you can get. And a scarf sign, you're taking the elbow and you're trying to bring it across the nipple line to see how those joints have grown and adapted, and heel to ear. So, in a 25-weeker, you can have, somewhere between a 1 and a 0. Usually you can move them right up, okay? So, a baby that's 25 weeks, you're gonna get about a 2 or a 3 total points up here. So here's your point value. So the baby's laying flat like this, so we'll give them a 1. The square window, depending on how you bend that wrist. is
How
gonna
would you
give you a
test for that? Could you just?
the square window?
Yeah.
You literally, you take their wrist and you go like that. A term newborn, you can bend right in half. They're so soft, you can do this. A preterm infant doesn't have the joint mobility yet to do it. So as you go extremely premature, they're getting some joint movement there and normal. And then by the time they're full term, they're flat. So, and it gives you the degree on how to do the Ballard assessment. So flipping to a full term baby, they have a normal posture. Their knees are up, their hands are up. You can bend their wrist right in half. You push their arms out, they come right back up to their face. Their popliteal angle, you keep their hip to the bed and you lift their leg up like that. You determine what angle you're at. Their scarf side, you can't really move them. They've got a fat layer, they've got tissue and everything in there. And then their heel to ear. You keep their butt on the bed and you try to bring their heel to their ear, and you really can't take them too far. A preemie, if you're doing this, if you're touching their ear, they're down in this low range. They're in the 24, 25-week range. Their skin, I have a 25-weeker, so I'm probably only going to get a 2 or a 3 down here, because remember my whole total points are only going to be in the 5 range, no higher than 5. So they're gelatinous, they're red, which is a finding that was different with the 25-weeker we saw. That baby's skin was intact. There was a layer of skin there. That baby weighed 440 grams and was really 23 weeks, like the baby in isolation was. Their skin literally had like a Wharton-y type gelatinous skin. So, their plantar surfaces, and a couple of you probably saw me look right at the soles of their feet when we were in the newborn nursery, and that's what I'm looking for. Full term, creases over the entire sole. Preterm, faint red marks, no lines. Some are just completely smooth. Same thing with their ears. A full term baby, thick, bounces right back. Cartilage is all intact. Preterm, you flip their ear like that, it stays like that. If they're on that side of the ear and the ear's bent forward, you flip them over, the ear just literally stays there. We have to keep flicking it forward to keep it together. So that's a Ballard scale. And when you flip to your second page, this is an indicator. This sheet would have been abnormal for the 25-weeker that we saw, because you take the weeks of gestation based on your Ballard, your length, head circumference, and weight, and you map it out on these. You want it to be, between the dotted lines there, and you determine if you have 2 areas, either the length, the head, or the weight off of the chart, then they are SGA, small for gestation, or they can be large for gestation, or they can be average, meaning all 3 are in the normal range. So that baby at 25 weeks was small, so it was small for gestation.
You have to have 2 off the charts though?
Yes. So we went over small for gestation is a birth weight less than 10% on the intrauterine growth curve. Large gestation is a birth weight above the 90th for the gestational curve. 10% of 23-week babies survive, 33% of 24 weeks survive, and 58% of 25 weeks survive. And then when you're 26 and greater, survivability is very good. 12% of all infants born throughout the United States go to a NICU, and 8 are preterm. So in the high-risk infant category, caring for them, most are preterm infants. So high-risk newborns can be based on birth weight, their gestational age, pathophysiologic problems, and congenital anomalies. For the extremely low birth weight infant, the 440 grams, the 500 grams, their risk is greatest in the 72 hours for survivability. You saw the baby, the 25-weeker, at 2 days of life, because it was prior to the 3-day held ultrasound. So that baby was already, saving itself there just by still being alive. A low birth weight baby is less than 2,500 grams. A very low birth weight baby is under 1,500 grams, and extremely low birth weight is under 1,000 grams.
Do you know what these weights are in pounds?
I do have a conversion chart. I'll put the conversion chart
Okay.
off the top of my head. 1,500 grams is 3 pounds, 3 ounces.
3 pounds?
1,500 is 3 pounds, yeah. And 1,000 grams is 2.2 pounds.
Yeah, 'cause that's my kilo.
So all
It's
newborns
slides.
have priorities in the first few days of life, okay? So regardless of what's going on with maternal history or everything else, the number one priority is the initiation and maintenance of respirations. Doesn't matter if they have a heart defect, it doesn't matter what else is going on, oxygenation is first. They have to be able to initiate and maintain respirations. Even if it's with the assistance of us, oxygenation is number one. So, we talked about fetal lung maturity. Vicki covered that in detail. So, determining that fetal lung maturity, if you have the availability, is a good indicator of wellness. Remember the medication that's given to moms to speed up lung maturity in premature infants is betamethasone.
That speeds up the lung maturity?
It does. Yep, it
It's a
speeds up.
steroid,
It's a steroid. It stresses the fetus, and it causes the fetus to start producing surfactant. It's given in 2 doses.
Is that what you showed us, or is that,
That was surfactant.
that was actual surfactant?
That was
Okay.
actual surfactant.
Yeah.
How long can you give artificial surfactant before regular surfactant is made?
We only give it in 2 doses.
That's it.
Yes. The normal course is 1 dose, 3 mLs per kilo, or, yes. But you can give it in 2 doses if you need to.
The surfactant?
So we had an elective, not elective, mom was starting to have some complications, but a 37-week male born Saturday, and he did get 9 mLs of Infisurf up in the NICU, and that was early in the morning, and they made the decision to have a 2nd dose, but that's all they would give. So, 2 doses. And there may be some variance from facility to facility, but after that, it doesn't show any greater improvement.
The betamethasone is given when?
The betamethasone is given between
Usually
24 and
it's
34 weeks. It's given IM, is it IM? 2
Yeah,
shots,
I am 2 shots,
12 hours
20
apart. Oh,
24 hours apart.
24 hours?
So you try to keep that pregnancy intact
Right.
until after,